You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about diuretic resistance and cardiorenal syndromes, a very common issue you will encounter in the management of patients with heart failure decompensation. We'll first go over the range of diuretic agents and where they act, then we'll talk about diuretic resistance concepts, then we'll go over the types of cardiorenal syndromes. Let's start with the diuretic agents. Diuretic agents can act at the glomerulus, the PCT, the loop of Henle, the DCT, which is the distal convoluted tubule, and at the collecting duct. At the glomerulus, you have ACE inhibitors or ARBs. ACE inhibitors or ARBs reduce intraglomerular pressure by dilating the efferent arteriole, thereby lowering the GFR and protecting against glomerular damage. NSAIDs constrict the afferent arteriole, reducing blood flow into the glomerulus and decreasing GFR. So they are usually harmful and should be temporarily discontinued. At the proximal convoluted tubule, you have acetazolamide, which is a carbonic anhydrase inhibitor that reduces bicarbonate reabsorption in the PCT, leading to mild diuresis and metabolic acidosis. SGLT2 inhibitors such as empagliflozin or canagliflozin inhibit the sodium glucose cotransporter 2, reducing glucose and sodium reabsorption in the PCT, leading to increased urinary glucose excretion and mild diuresis. At the loop of Henle, you have loop diuretics such as furosemide, bumetanide, and torsemide. These inhibit the sodium-potassium 2-chloride cotransporter in the thick ascending limb, blocking sodium, potassium, and chloride reabsorption, leading to profound diuresis. Mannitol also acts here. Mannitol increases the osmolarity of the renal tubule, drawing water into the tubule and increasing urine output. At the distal convoluted tubule, you have thiazide diuretics such as hydrochlorothiazide, chlorthalidone, and indapamide. These inhibit the sodium chloride cotransporter in the distal convoluted tubule, leading to increased sodium and water excretion and mild diuresis. These are calcium sparing. At the collecting duct, you have aldosterone antagonists such as spironolactone and eplerenone. These block aldosterone receptors in the collecting duct, reducing sodium reabsorption and potassium secretion. This leads to mild diuresis. There's vasopressin antagonists such as tolvaptan. These inhibit the action of the antidiuretic hormone on the V2 receptors in the collecting duct, leading to water diuresis or aquaresis without affecting sodium. These can be used in hyponatremia, especially in SIADH, but it's not routinely used in congestive heart failure. Then you have the potassium-sparing diuretics, such as amiloride and triamterene. These block sodium channels in the collecting duct, reducing sodium reabsorption and preventing potassium excretion, which helps prevent hypokalemia. To understand diuretic resistance, we should first understand the loop diuretics journey from mouth to kidney. This journey is fraught with many potential barriers. First, the absorption of loop diuretics, especially furosemide, is subject to variability from food intake and degree of intestinal edema. The bioavailability of oral furosemide ranges from 10 to 100%, whereas the bioavailability of oral torsemide and bumetanide are higher and more consistent at over 80%. Second, in states of hypoalbuminemia such as malnutrition or nephrotic syndrome, there is less delivery of diuretic agent to the nephron, since diuretics are transported in the blood by albumin binding. If there is substantial albuminuria, the excess albumin in the tubular fluid can bind to the tubular diuretic, preventing the diuretic from acting on its receptors in the loop of Henle. Third, renal perfusion pressure depends on the gradient between the mean arterial pressure and the central venous pressure. In congestive heart failure, mean arterial pressure may be low or central venous pressure may be high, causing reduced renal perfusion pressure, which not only reduces the amount of water and solutes filtered at Bowman's capsule, but also limits the secretion of loop diuretics into the proximal convoluted tubular fluid. Fourth, Loop diuretics are competing against other organic anions such as NSAIDs, beta-lactams, methotrexate, urate, and urea for access to the OAT channel, the turnstile that allows these organic anions to cross from the bloodstream into the lumen of the proximal convoluted tubule. Presence of these competitors will reduce diuretic entry into the proximal convoluted tubule lumen. Fifth, for loop diuretics to carry out their work, there must be viable cells with working sodium-potassium 2-chloride cotransporters in the thick ascending limb. Both CKD and AKI can involve injury of cells in the thick ascending limb. When there are less functioning cells in the nephron, it is harder for loop diuretics to find targets to act on. Therefore, the maximal response to a diuretic decreases as AKI or CKD worsens. 21% of diuretic resistance cases are attributable to one of the mechanisms above involving impaired proximal tubule secretion or incomplete loop of Henle blockade. However, 79% of diuretic resistance cases are due to increased sodium reabsorption in the distal convoluted tubule and collecting duct, also known as heightened sodium avidity. Loop diuretics, when delivered in inadequate amounts to viable cells, work by shutting the door to sodium reentry at the loop of Henle via the NKCC2 cotransporter. However, there are 3 more doors that could open down the road: the sodium chloride symporters in the distal convoluted tubule, the epithelial sodium channels or ENaC, and the sodium-dependent chloride bicarbonate exchangers NDCBE in the collecting ducts, all of which can reabsorb sodium back from the tubular fluid into the bloodstream. Contrary to initial belief, compensatory post-diuretic renal sodium reabsorption at these sites is not the main mechanism of diuretic resistance in acute heart failure. Instead, chronic heart failure is characterized by persistent RAAS overactivation, which induces structural changes in the distal tubule and collecting duct that cause a persistent sodium avid state that also persists through acute heart failure. Chronic aldosterone elevation in chronic heart failure leads to chronic activation of the ENaC and NBCDE pendrin system in the collecting ducts, increasing these receptors for sodium reabsorption. Chronic aldosterone elevation also causes hypertrophy of the distal convoluted tubule, which increases the total number of sodium chloride symporters in the distal convoluted tubule for sodium reabsorption. Therefore, independent of what amount of diuretic is delivered to viable cells in the loop of Henle, sodium may still be getting reabsorbed at high rates by these distal tubule and collecting duct receptors, upregulated by chronic RAAS activation. Because of the mechanisms described above, there is value in sequential nephron blockade. So, what exactly is this concept of sequential nephron blockade, or nephron bomb, as some like to call it? Components of nephron blockade that act on the proximal tubule secretion are incomplete loop of Henle blockade, which is the first 21% of cases that I talked about, are acetazolamide, SGLT2 inhibitors, and loop diuretics, which are already assumed to be on board. Acetazolamide, which is a carbonic anhydrase inhibitor, reduces bicarbonate reabsorption in the proximal convoluted tubule, decreasing sodium reabsorption in the proximal convoluted tubule and therefore greater diuresis, and also metabolic acidosis. SGLT2 inhibitors inhibit the sodium glucose cotransporter 2, reducing glucose and sodium reabsorption in the proximal convoluted tubule, leading to increased urinary glucose excretion and therefore greater diuresis. Components of nephron blockade that act on the sodium avidity part of the distal tubule and collecting duct are thiazides, potassium-sparing diuretics, mineralocorticoid antagonists, and vasopressin antagonists. Thiazide acts on the sodium chloride cotransporters, or NCC, in the distal tubule, which decreases reabsorption of sodium in the distal tubule. Amiloride and triamterene, which are the potassium-sparing diuretics, act on the epithelial sodium channels, ENaC, in the collecting duct, which decreases reabsorption of sodium in the collecting duct. Spironolactone and eplerenone, which are mineralocorticoid antagonists, MRAs, act at the mineralocorticoid receptors in the collecting duct, which decreases reabsorption of sodium in the collecting duct. Tolvaptan, a vasopressin antagonist, inhibits the action of antidiuretic hormone on the V2 receptors in the collecting duct, leading to water diuresis or aquaresis without acting on sodium directly. Now that you have this background of what exactly nephron blockade is and how it works, we can go over a framework, a systematic approach to diuretic resistance management. In this systematic approach to diuretic resistance management, first, be sure to exclude causes of pseudo-diuretic resistance, things like urinary tract obstruction, inaccurate isonos or weights, total body euvolemia with lymphedema or hypoalbuminemia, and medications that interact with diuretics. Then, the starting dose of your diuretic should be at least 2 times the oral home dose equivalent intravenously. Then, you should check spot urine sodium within 2 hours of administration of your IV diuretic. If the spot urine sodium is less than 70 milliequivalents per liter, then you need to double the dose of IV loop diuretics. Spot urine sodium allows you to reassess every 2 hours, whereas relying on urine output involves a slower reassessment period of every 6 hours. The 6-hour urine output should be at least 100 milliliters per hour. If the frequency of loop diuretic administration is less than every 6 hours, increase the frequency to every 6 hours. Sequentially step up the loop diuretic dose until you are at 300 to 500 milligrams of total daily equivalent of IV furosemide. Some thought leaders advocate for furosemide 500 milligrams TID or bumetanide 12.5 milligrams TID. As maximal loop diuretic dose is approaching, ensure that sequential nephron blockade is on board. First line is thiazide, such as hydrochlorothiazide up to 200 milligrams of total daily dose, or metolazone up to 20 milligrams total daily dose, or chlorthalidone up to 100 milligrams total daily dose. Opinions are mixed as to whether SGLT2 inhibitors such as empagliflozin 25 milligrams should be added up front or deferred until after acute decongestion. Next line is carbonic anhydrase inhibitors such as acetazolamide, given as 500 milligrams PO or IV up to 3 times a day. Second line could also be a potassium-sparing diuretic such as amiloride up to 20 milligrams of total daily dose. MRA such as spironolactone can also be considered up to 100 milligrams. Note that up to 400 milligrams is used in hepatology, so don't be scared of using 100 milligrams in heart failure exacerbation. Third line is dopamine drip at 3 micrograms per kg per min versus hypertonic saline, but the evidence is mixed on this, and not everyone is going to agree with you on this idea of dopamine drip or hypertonic saline. And of course, the last line is ultrafiltration as a bailout strategy. Now that we've gone over a systematic approach for diuretic resistance, we also need to know that there's more than one type of cardiorenal syndrome. 5 types of cardiorenal syndrome exist, defined according to the direction of effect and chronicity of action. Type 1 cardiorenal syndrome is characterized by acute cardiac decompensation leading to acute kidney injury. Type 2 cardiorenal syndrome is characterized by chronic cardiac dysfunction, chronic heart failure, causing progressive chronic kidney disease. Type 2 CRS, also referred to as acute renal cardiac syndrome, is characterized by acute kidney injury precipitating acute cardiac injury. Type 4 CRS, also referred to as chronic renal cardiac syndrome, is characterized by chronic kidney disease such as glomerular disease, contributing to progressive cardiac dysfunction, which can be systolic or diastolic heart failure, ventricular hypertrophy, or an overall increase in major cardiac events. Type 5 CRS is characterized by simultaneous occurrence of cardiac and renal injury from an underlying common insult. The bottom line is that cardiorenal syndrome should not be treated as a homogeneous single entity. Identification of the directionality of the injury and time course of the injury can inform appropriate treatments. What exactly is happening within each type? So let's delve into each type of cardiorenal syndrome. Type 1 CRS, which is acute cardiac decompensation leading to acute kidney injury. Acute heart failure can be from hypertensive pulmonary edema with preserved LV systolic function. It could be acute decompensation of chronic heart failure, cardiogenic shock, or even predominant RV failure. So it's a broad definition. Acute cardiac decompensation can also be from myocardial ischemia or cardiac surgery. The primary mechanism is hemodynamically mediated damage, as decreased cardiac output leads to decreased perfusion of all organs, including the kidney, leading to increased venous pressure, reduced glomerular filtration rate, and reduced oxygen delivery. Heart failure is characterized by a state of renin-angiotensin-aldosterone system activation, which involves vasoconstriction and retention of sodium and water, as well as inflammation, causing cytokine secretion and immune-mediated damage. Cardiorenal syndrome type 1 has an acute elevation of reactive oxygen species and reactive nitrogen species, coupled with increased expression of interleukin-6 and myeloperoxidase. Exogenous factors such as use of contrast media and cardiac catheterization, ACE inhibitors, or diuretics can also cause renal vasoconstriction. How about type 2 CRS, which is the one where you have chronic cardiac dysfunction causing progressive chronic kidney disease? The hypoperfusion of chronic heart failure leads to chronic hypoperfusion of all organs, including kidneys, chronic venous pressure elevation, and increased renal vascular resistance, leading to sclerosis, fibrosis, and apoptosis. Chronic heart failure also involves a state of chronic inflammation, oxidative stress, and neurohormonal activation, causing chronic neurohormonal insult as described in cardiorenal syndrome type 1, but in perpetuity. Type 3 CRS, which is the one that is characterized by acute kidney injury precipitating acute cardiac injury, also known as acute renal cardiac syndrome. The acute kidney injury may arise from any cause, including acute tubular necrosis, acute interstitial nephropathy, acute pyelonephritis, glomerular diseases, or acute urinary obstruction. The reduced glomerular filtration rate and sodium and water retention of AKI can lead to acute fluid overload and increased preload that precipitates acute heart failure, acute myocardial ischemia, or acute pulmonary edema. Hyperkalemia from AKI may contribute to arrhythmias. Untreated uremia can lead to accumulation of uremic toxins that lead to acute pericarditis or depressed myocardial contractility. Acidemia from AKI can cause pulmonary vasoconstriction, which can contribute to right-sided heart failure. Acidemia also has a negative inotropic effect. In experiments of induced acute kidney injury ischemia, the rise in circulating levels of TNF-alpha, interleukin-1, and interleukin-6 have direct effects in reducing LV ejection fraction and elevating LV end-diastolic and end-systolic volumes. How about type 4 CRS, which is chronic renal cardiac syndrome? The reduced glomerular filtration rate and chronic volume retention in CKD can accelerate left ventricular hypertrophy and heart failure via chronic pressure and volume overload. LV hypertrophy is highly prevalent in patients starting hemodialysis. It can also accelerate ischemic heart disease via a chronic state of hypoperfusion. The introduction of arteriovenous fistulae for hemodialysis also predisposes to high output heart failure. CKD is also characterized by malnutrition and secondary hyperparathyroidism, with calcium and phosphate abnormalities that impair myocyte contractility, as well as chronic anemia, which leads to decreased oxygen delivery. The chronic calcium abnormalities of CKD also lead to calcific valvular disease and chronic coronary artery calcification due to osteoblastic transformation of vascular smooth muscle cells. Uremic toxins, chronic inflammation, chronic FGF23 elevation, and chronic neurohormonal abnormalities also lead to cardiac remodeling and myocardial inflammation. Significant shifts of electrolytes and blood volumes during intra and interdialytic periods may lead to relative ischemia and regional wall motion abnormalities, as well as precipitate cardiac arrhythmias. Lastly, patients with CKD almost always have concomitant obesity, hypertension, dyslipidemia, and smoking, which also accelerate cardiac dysfunction. Now, type 5 CRS, which is the one where you have occurrence of cardiac and renal injury from an underlying common insult. Examples of these are sepsis, drug toxicity, vasculitis, lupus, diabetes, cirrhosis, sarcoidosis, amyloidosis, or other systemic diseases. CRS type 5 can be acute, as in sepsis, or chronic, as in cirrhosis. I know that was a very deep dive, but I hope that this allows you to think of cardiorenal syndrome in terms of the mechanisms and the pathophysiology, not just as a list of 5 different items in like a laundry list. A few other details. Increased, not decreased systemic venous pressure is what contributes to the development of cardiorenal syndrome most of the time, because venous congestion leads to elevated intra-abdominal pressure, which can impair glomerular filtration. An increase in BUN out of proportion of serum creatinine would be a sign of renal hypoperfusion, resulting from low cardiac output or intravascular depletion because of high doses of IV diuretics. This is because the neurohormonal activation that occurs in renal hypoperfusion increases proximal sodium and urea reabsorption in an attempt to address the hypoperfusion, while handling of creatinine is unaffected, leading to an elevated BUN to creatinine ratio. Why is it that BUN to creatinine ratio is more than 20:1 in pre-renal AKI? In volume depletion, reduced renal blood flow leads to a release of renin from the afferent arterioles to produce angiotensin II, which vasoconstricts the efferent arteriole to preserve filtration. Yet, this adaptation is often not enough to maintain filtration in severe volume depletion, so blood urea nitrogen and serum creatinine levels rise. Angiotensin II also increases sodium reabsorption throughout the nephron, especially in the proximal tubule where urea is absorbed. Therefore, in volume depletion, the urea concentration rises higher than the creatinine level. Situations in which FENa can be less than 1% even if there is no volume depletion are cirrhosis, because splanchnic vasodilation pools blood at the intestine vessels and reduces the blood in the rest of the body circulation, including renal circulation. Severe CHF, because the kidney activates RAAS. Contrast nephropathy, because of renal vasoconstriction. Acute glomerulonephritis, because the tubules can react to GN by sucking up sodium. And rhabdomyolysis, because it worsens renal vasoconstriction. Those are the situations where FENa, fractional excretion of sodium, can be less than 1%, even if there is no volume depletion. So you should also keep that in your differential. That's a wrap on our episode on diuretic resistance and cardiorenal syndromes. I hope this is helpful to you.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.raahu.com/meded.